my shoeless shoes. Yeah.
Okay, so picking up at skin, what's important about the skin of our feet is that our skin has to stretch and expand with every step and then contract as we lift our foot off the ground. So with all those 5 to 10,000 steps a day, our skin has to be strong to resist that impact and friction, but also elastic to absorb some impact and expand with the way the bones and joints move underneath it. So that's a unique need of the feet. That's also why the skin needs to be healthy in terms of having the right level of hydration and not having areas that get too thick or hard or calloused. So part of as we get older, our skin tends to get thinner, drier, less elastic. So sometimes our patients need to start using lotions to make sure their skin's doing well with that kind of stuff. But it sounds funny, and you guys have maybe seen this even in the winter. Our skin gets a little bit drier in the winter, and sometimes it's less resistant to friction or pressure. And sometimes people have more problems with skin or calluses during the day. I should say during the winter time. The other thing is that the skin on the bottom of the foot is twice as thick as skin other places. And so that's part of why our foot tends to be a little bit more resistant to some of that impact force. But there's skin all over the body is not the same, and the demands on the skin of the foot is different than it would be on the hand. An older patient can be prone to things like cracks or fissures. You probably can't see that from where you sit, but dry skin can actually break open, and this is a good example. Her skin is not elastic enough to stretch when she bears weight, so it started to crack. That's something that you have to treat in clinic, and there are some good lotions that you can use too. You guys don't carry lotions here though. Yeah, I don't know if you'd necessarily want to. Nail changes. Do you guys get people asking about nail issues? Good. We'll kind of skip over that. It can be a problem fitting a shoe though. Once in a while you get someone that maybe looks like this and you may need some extra depth, or you may just say, you know, have those looked at or have someone help you reduce some of that thickness. I'm going to skip over skin issues, but here's some good pressure mat stuff. A pretty big callus here, pretty big callus there. Here's a pressure mat that shows those. You know, here's a computerized version of the pressure mat that you guys are familiar with. And those are things we can offload with things that you're familiar with, a metatarsal pad and a little bit of an arch support. I'll skip over the ulcer part. You guys don't need that, but you certainly can get some pretty significant infections. The fat pad on the bottom of the foot, so we talked about fat pad atrophy. So once we're over age 25, this is when we start to age. So it sounds kind of young, right? Are most of us over 25? Yeah, so we're all old according to some of the research. But not only do we lose, you know, some atrophy of the skin, but our soft tissue atrophies too. So this is an MRI of a fat pad. This would be the heel bone, the calcaneus, and this is the fat pad. That's our natural cushion. After age 25, we start to lose that cushioning. So that's part of the reason some people will have bony prominences and tenderness, especially on the ball of the foot, not as much on the heel. But that's certainly an issue when it comes to pain on the bottom of the foot. It's why some people may benefit from a little more cushioning. It's why a lot of our patients come in and say, I'm not really comfortable walking barefoot around the house anymore. And that's when we kind of steer them towards things that might be good as a house shoe or an insole. And symptoms you can get related to that atrophy of the fat pad are metatarsalgia, so achiness up in the metatarsals or the forefoot, capsulitis, which is inflammation of the joints, especially the joints at the bases of the toes. Neuromas are relatively common related to this. Calluses, as I mentioned. Heel pain. Most heel pain is plantar fasciitis. I'm pretty sure you guys are familiar with what that is, and we can talk about that in more detail maybe towards the end. But some heel pain is from atrophy of the fat pad and there not being enough cushioning around that bone. And just generalized discomfort from being barefoot. Tendon injuries. You guys may have seen some people that pronate so severely that they practically fall right off of their shoe. Not only can you have a pronated or a flatter foot type, but females, especially between age 40 and 60, are more prone to a condition called posterior tibial tendon dysfunction, where the posterior tibial tendon, which is a big tendon that comes along the inside edge of the ankle, becomes so overloaded and weakened that it starts to actually stretch or tear. And this would be a right foot that is in valgus or everting so much. We had to actually put a patient like this into a brace to be able to control that significantly. These work great. It's a custom-made brace, but it's relatively bulky. I try not to use it if I don't have to. I'll first start with some insoles and a really stable shoe. Tendon injuries, I can skip over that for you guys. Blood flow changes, so swelling and varicose veins are common, and that makes it a little bit trickier fitting people, of course. Do you guys get people asking a lot about, or coming in later in the day with a really swollen foot and wanting to be fit for a shoe when they're swollen, or vice versa, saying I came in now to fit now when I'm not swollen? it can certainly create issues. And you can't necessarily predict how to fit a foot that fluctuates in size, right? My best advice, and you guys don't want to get into too much about discussing swelling or managing swelling, but in clinic, I would tell a patient to use a compression stocking to manage it. People don't like using compression stockings, though. They're not comfortable and they're hard to get on. There are over-the-counter compression stockings that can be purchased. Do you carry compression stockings here? Yep. Compression socks, yep. So those, the non-prescription strength of those is 25 millimeters of mercury and below. If those don't work well, then there is a prescription strength of them. They have to get that through a doctor, obviously. But I think those are easy to suggest to people as a starting point to help manage things, but in general, people don't love to use them. But again, as it relates to fitting a shoe, there's not an easy way to predict what volume they need to manage both their non-swollen state and their swollen state. It's very tricky, and those are the ones that you might refer first to be evaluated. And you know, they're obviously easier to get over the counter now. A lot of running shops are carrying them too. The benefits of them in terms of performance for runners, there doesn't seem to be a performance benefit. There is some research that suggests there might be a recovery benefit with them. I've used them myself. They're okay. I don't know if I've noticed any dramatic changes. Bone and joint changes, so older patients are more prone to arthritis and bone spurs. This is a big spur on the top of an ankle, big spur on the bottom of the heel. Sometimes those bony prominences are obvious, and it requires either some kind of creative lacing pattern changes to get pressure off, something like that. Other times it can be just having the shoe stretched. I know you guys do that here. I think starting with a stretching of a shoe or a more stretchable soft leather upper is a good starting point for patients, and even in clinic I recommend they do that first. If they still have issues, then we'll say, all right, we might have to go in and surgically resect that prominence. Hallux rigidus. So this is that arthritic condition of the big toe joint. This is the second most common site of osteoarthritis after the knee. So you guys have probably seen this. In fact, a lot of our patients will come in and say, I have a bunion, but they don't really have a bunion. They have a bony prominence and a rigidity and pain of the big toe joint. So again, probably a slide you can't see real well, but they'll get a bony ridge on the top of the joint, and then the joint space closes down so that big toe doesn't bend as well. Those people, and maybe you guys have seen this because I very often recommend a stiff shoe and a 4-foot rocker for those. The idea being that the big toe can't bend very well anymore, so if the shoe doesn't bend there, it's going to relieve some pain. So that's where I tend to like the Danskos, the Clark's Wave, the Walkies, a nice stiff shoe that helps them get up and over their 4-foot. And what I'll tell my patients in clinic is that shoe is a tool. It doesn't mean every step of every day for the rest of your life you have to use a stiff shoe that doesn't bend or has a 4-foot rocker. They're going to use it as much as they need to be happy. They're going to tend to have more pain if they're in a more flexible shoe, but it doesn't mean they can't use them.
I have a question in reverse to that. What shoe do you recommend for a person? What do you recommend a flexible shoe to a person who has a certain foot problem that they need a flexible shoe versus a rigid shoe?
Well, it really depends on what we're treating or what their issue might be. If I look at any shoe as a tool, and I use a wide variety of shoes myself, from the Vibram 5 Fingers all the way up to a stiff, supportive hiking boot. So it really depends on what their need is or the question is. Some people want a flexible shoe that doesn't have a lot of support, and I would say that in general it's healthy for us to have different types of footwear so that we won't have the same stress day after day, step after step. But every person is different in terms of what their range is on comfort. There are plenty of people that can tolerate super flexible Vibrams as well as a Dansko shoe. There are others who can't really do well on that flexible end. So I would just tell a patient, if it was someone that had no foot pain at all, I'd say yes, they're worth trying. But if it was someone who was prone to foot pain, I'd say in general, I wouldn't recommend a flexible shoe. It's not going to be therapeutic. I wouldn't tell them they can't use it, but I'd say that I would err on more supportive side until you're happy with how your foot feels, and then introduce something more flexible and see if you like it or it's comfortable or helpful. Does that answer your question? Yeah, okay. So yeah, this is relatively common, and typically you're going to see a bony ridge across the top of the joint as opposed to a big angle like a bunion would be. And I'll tell you too, some people have a hybrid deformity. Some people have arthritis and a bunion at the same time. It's a little bit trickier to recognize. Related to this, if that big toe joint doesn't bend well, sounds funny, but they can also be prone to plantar fasciitis. So the way that the windlass mechanism, the plantar fascia works, if this isn't bending, it increases strain on the fascia, and we can talk about that a little bit too. How are we doing for time, Jim? 5? Okay. Osteoarthritis of the foot and ankle. So again, another area that's relatively common. When you have someone who complains of midfoot pain, looks like they might have some swelling, and even just a change of shape to their midfoot, usually they're going to have arthritis. You have to look at an x-ray to really determine that. But the symptoms tend to be achiness or pain in their midfoot or arch. People that have early stages of arthritis with this usually do pretty well in an insole, in addition to a good supportive shoe. So with treating someone who has arthritis in their feet, stiffer, more supportive shoe. That's, I think, the ASIC's probably 2060 from back in the day, but a medial post. And then if for midfoot arthritis, are there very many double rockers around anymore? It's kind of died, right? Yeah. These can be therapeutic for some people, but of course they also disturb balance. So there's kind of a trade-off there. But I think the forefoot rocker is the one that's around still, that's a little more useful. And again, because it's got that forefoot rocker that tilts, that modifies or decreases some of the bending forces that go through some of the bones and joints of the foot. It basically is helping or assisting us in the sagittal plane and moving forward. Insoles, I think, are a good piece of the puzzle for arthritis, whether it's an off-the-counter, custom-made, and I will even use like a rigid carbon plate, which is like kind of something that's a couple millimeters thick that goes underneath the insole of a shoe, and basically is like having a leaf spring underneath their foot. I'll use that a lot for runners, triathletes, walkers who have arthritis of the big toe joint. When I first started using them, I didn't think people would tolerate them, but they do work well. One thing I'll emphasize, too, related to that, is there is research that shows if you have arthritis in your big toe joint, or pain in your foot, it affects your gait all the way up into your hip and low back. And so, like, patients will ask me, well, if you give me that plate, won't it affect how I move? And the answer is yes, it will. But having pain or stiffness in your big toe joint has already affected how you move, too. So your gait pattern is pretty much permanently changed, but these are tools we can use to try to help find maybe a less painful gait pattern for you. I'm not going to talk too much about neuromuscular gait control, but what I think is cool about this is there's research that shows the mechanoreceptors, the little sensors on the bottom of our foot. A lot of people call them proprioceptors, but proprioceptors are more in the joint. But the way that our foot senses the ground affects muscle activation in our legs and our neurologic system all the way up into our gluteal muscles and low back too. So sensation of our feet is important about how we move. We lose sensation as we get older, and that's one of the theories or one of the pieces of the puzzle in terms of why we also start to lose our balance. We're not sensing the surface as well. We don't trust the signals, or we're not getting the signals we need to balance and sense the surface that we're landing on. And the other thing I'll emphasize is that shoes are a filter. And we might start to wrap it up on that note too. We're okay? And this is Benno Nigg's work, and I think he's one of the most fascinating researchers on footwear. But our foot is a sensory organ, and so our foot gives us signals on the surface, the texture, the alignment of the surface that we're landing on. Our foot filters that information, and this kind of ties into the whole debate on barefoot and minimalist running, and that's a whole another issue I'm happy to talk about at another time. So when we have shoes on, they're all affecting how we move, because a lower profile shoe will filter that sensory information differently than a stiff, rigid, or really thick or soft shoe. And so our movement patterns are significantly affected by all of those things. Now, there isn't an easy way to predict what the right level of cushioning or support or alignment is for any of us. And that's why this always ends up being a trial and error process in terms of trying to fit a shoe. But learning to kind of tune in on what someone likes or doesn't like about a shoe is important. And one of the studies that I cite a lot or discuss a lot is one of them that Nigg did, and maybe some of you have heard me talk about it, where in terms of comfort, he took a group of runners and gave them 5 different shoes and had them spend a week getting used to those shoes. They then came back to his lab and they rated the shoes from most comfortable to least comfortable. He then put them on a treadmill and tested their VO2 max, so that's a way to kind of measure their metabolic movement pattern and how they use oxygen for energy. He found that the runners, or the shoes that were rated as most comfortable, the runners were most efficient in metabolically. So the study's interesting in that it points out that the way that we perceive comfort has to do with probably our movement patterns. And if a shoe is working with our movement pattern and helps us move efficiently, it'll probably feel more comfortable. If it's working against our movement pattern and making us work harder, it may not be as comfortable for us. So I like that study because it helps us kind of put the comfort thing back on the customer and say, you need to kind of determine what's comfortable for you, because that's probably a good sign about how you move in it. It's also why we have to have these people moving in their shoes and not standing in it. Okay, so I think that's an important study. Yes?